So this is a middle-aged woman and she complains of pain in right lower quadrant. Ultrasound is done. That's the appendix. And we see two protrusions out of appendix. It wasn't very clear about the cystic or they were mass-like. So MR is done. Basically, they're outpouchings from the appendix, appendicular lumen. So they are diverticula of the appendix.
That's
We see
a really
another
thick
video.
appendix.
Say it again.
It's a really thick appendix too.
Yeah.
Okay.
And then eventually appendix was removed and she had subacute to chronic appendicitis on pathology.
Very cool. So is that what caused the diverticula too? The inflammation or?
Think so. Because like if we see the fat around the diverticula is pretty clean. And we have seen a couple of cases of diverticula in which like, appendix itself is unremarkable and diverticula themselves are unremarkable. Although yes, diverticulitis of appendix can also occur. But more or less they're like incidental findings and they can be misdiagnosed as like probably abscess. Say if it was full-blown appendicitis, acute appendicitis, this could easily be thought of as abscess.
Yeah, or like a contained perforation.
Yeah.
Do you guys know SCAD?
Yes.
Segmental colitis with associated diverticulosis. It reminds me of that. I guess that was my question is like, did the diverticula happen because there was chronic appendicitis, like chronic inflammation that caused it to kind of like outpouch like this? I guess we'll never know. But if that was the case, then it would be almost like the appendicular version of SCAD.
Yes.
That sounds reasonable. I was thinking the same thing.
Because we don't see diverticula that common. It seems like, and then this appendix is super thick. But yeah, really cool case. Thank you.
Thank
you. This is a patient who had liver disease and a screening MR. So this is the MR actually here. So the lesion in question is rim enhancing. It's right here, this thing. Right there.
Rim aphy, LRM, possibly cholangio.
Okay. Here's the 5-minute. And then here's the diffusion. It doesn't restrict. It's right there.
Wait, is the rind restricting? No, not really.
Right there.
The peripheral rind isn't really. Okay.
And let me show you the T2 again. That's the T2.
An atypical hemangioma, but I don't feel like you can call it like that. We have seen cholangios that have been really T2 bright and really avidly enhancing, actually. I think you still have to call it an LRM.
Good. Okay, the patient got a biopsy and it was benign. But they saw something else on ultrasound.
But doesn't like super high, like it's super bright on T2, that is reassuring that it is benign? Cholangio won't be that bright.
We've seen some cases in this conference where it's been really bright.
Okay.
I guess like if it's not a typical hemangioma, right, on the other phases, like I don't think you can. I think you still have to call it LRM. What do you guys think?
I agree with you. I called it LRM. And I'll tell you what it was. Let me pull up the ultrasound.
Okay, hold on.
These are the ultrasound findings. There's flow in it.
Yeah, wait, is that like a lot of flow right there? Like a pseudoaneurysm? Wait, that doesn't make any sense.
And this was, and then it was subsequently embolized.
Wait, that big blob, is it?
Yes. Yeah.
Whoa. So it was like a
Yeah.
spleen?
Flash filling hemangioma.
What's that? It's a pseudoaneurysm from the left hepatic artery, or it's like actually a portal vein. Sorry, excuse me. Yeah.
Oh, wow.
Yeah.
Oh, wow. And it didn't look like a flow void on MR, probably because it was so slowly filling.
Yeah, it was a portal venous kind of aneurysmal. Yeah.
Oh, wow.
Yeah, and yeah, it was it was an LRM due to the rim enhancement, but vascular lesions cannot. I mean, it makes sense, like in retrospect, to explain the MR signal.
By the way, did they actually biopsy it? Because on ultrasound, they saw that much flow. They seems like they wouldn't biopsy it.
It was there was a contrast enhanced ultrasound that was actually biopsy was done, and then subsequently we got a contrast enhanced ultrasound which confirmed it to be a vascular lesion, and then we embolized it. Or sorry, we didn't embolize it. We put thrombin in it.
Oh, cool.
Because I'm going to meet you guys, right?
Okay, hold on. So this is the case.
Pancreatitis acute.
Yep. There's pancreatitis.
Did I
There's
see something in
bill,
the gallbladder? There's some.
or there's something at the head of the pancreas. There's like this ill-defined, like low density.
Good, 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 good. So that is kind of the point of this case that I wanted to point out.
And Bill Dill.
It's easy to we see the pancreas, but don't forget, there's Bildil here. And then there's actually this ill-defined, hypoenhancing mass here that was ended up being biopsy-proven adeno. So my teaching point is don't just get excited about the pancreatitis, any pancreatitis, especially if there's a little bit of ductal prominence here, but if you don't really have a good cause for it, there could be an underlying mass. And I'll show you, and then especially the clue here is that there's Bildil. They ended up getting an MR. Unfortunately, for whatever reason, it was a non-con, but the MR is very helpful. You can see that there's severe Bildil. And then we've got this evil gray mass here with some little dilated side branches in it. And the pancreatic duct is going away right there. And then very clearly on the diffusion, you can see that there's actually a pretty big mass here.
Do you have the T1s?
Yes, I have the T1, and also there's no post contrast, but yes, I do have T1 pre. I got some measurements here, but yeah. The rest of the gland is not the brightest, so it's not the greatest contrast, but yes, there's that.
I like the diffusion in T1s for pancreas.
Yep. Hold on one second. Here's just another companion case. Again, there was a little bit of stranding near the tail of the pancreas, near the head. I thought this was a really good call because this one's a little subtle, but the pancreas is atrophic. And here you can see if you narrow the windows, you've got the double duct. And then it kind of disappears here. This was a non-contrast exam for abdominal pain. If you're not looking, you could miss that, but it was called. And then the patient got an MRI. Oops. Now we see the double duct really nicely. And again, there's the lesion. You can actually see the flow void of the SMV being pulled and narrowed here by this cuffing of the soft tissue. And I'll show you some other phases. Here's our pre-contrast. The atrophic gland is pretty dark, but then here's the lesion. And arterial phase, really nice. So double duct, and then this hypoenhancing mass standing out right there. And then here's the diffusion. Right there.
Nice. Do you have the diffusion for the rest of the pancreas? That's fine.
Yeah, so it's definitely darker, and Rest of the pancreas not that bright, and then here it's brighter. I find it interesting, like here it looks much bigger than what I would have measured here. I don't know what you guys think, but I usually kind of use either the arterial or the pre. I don't know. I kind of like just try to combine them to try to get like but I don't know. I feel like sometimes the diffusion looks a lot bigger. I like the T2. Like I probably would have measured this whole thing.
Yeah, TT looks good. I think the post-contrast is probably underestimating the lesion size.
Yeah, I was thinking actually because like the rind could be, it's not just the hypoenhancing part. The rind could be like the more viable tumor on the outside and then like more fibrosis centrally.
Yeah, so I think probably the diffusion would capture the true volume better than the post-cons.
Yeah.
But
Okay.
like in LIRADS, we do not measure size on diffusion because it is always overestimates the size. So I think T2 definitely is a happy medium there to measure.
I like that. I like that because it does feel like the diffusion often in panc cancer is bigger. Okay. This.
There is loss of fat plane with the IVC. This area looks very
Area?
bright. Yeah.
Yeah, good. And there's also, this is really, I think, hard because it's non-con, but like there's just some fullness here, right?
Yes.
Liver, not that impressive, right?
Yeah.
Okay. Wait for it. This is the MR. There is actually, this whole thing is a mass. And it's actually a pancreatic adeno that's arising very low down from the uncinate, and it's thickening and eventually it obstructed the duodenum as well. But you can see how you can see everything so much more nicely on the MR, right? And I'll show you a couple of other phases. This was the arterial phase, where that was like the main thing. But there was still actually like some spread of tumor over here. And then this is the diffusion. Look how big it is. Okay, now it's scary part. Look at the liver.
Oh, wow.
Oh,
Could not even see anything on non-contrast CT, and it's just full of liver mets. All these little ill-defined hypoenhancing lesions. Nicely seen.
we do a PET MR.
Do I have more? Or you're saying?
We do. No. Like we do a PET MR as part of the staging process. So because we can do CT as well. And CT we use for vascular findings. And I was wondering what the added value of PET MR was. MR, they use MR, I found out, to look for exactly this, liver metastasis, because it has the highest sensitivity for liver metastasis. And then the PET part is to look for FDG avidity, because if it responds to neoadjuvant chemo, then it has a very good prognosis for patients. When you're showing the MR, it just made me think about our protocol for staging workup, and it seems excessive to get a CT, then an MR with a superimposed
You do PET MR
PET.
for every new pancreatic adeno diagnosis.
Staging, yeah.
Wow.
Like locally advanced.
I remember we were starting to do them, but then it fell off, and I don't know if it was because of reimbursement or what, but we kind of stopped doing them.
Isn't PET, that is the functional imaging, going to be more sensitive than even MR?
PET for more sensitive for what?
For detecting liver lesions or no?
No, because you have background uptake. Like these little small ones, you're not gonna pick up on PET. Because I mean, doesn't have like it needs to be a minimum size, like for the resolution of PET or something, right?
Okay.
Yeah. Okay, I have one more. Okay, this is just another interesting. So we've got a mass here. It's like pushing and affiliated with the pancreas.
It's like calcifications in it too.
Mm-hmm. Calcifications, good observation. It's encasing the arteries, but it did take out the splenic vein. So splenic vein is occluded because one thing we thought like it could is
like
it
a neurogenic tumor.
we also thought about like lymphoma, if it's
Lymphoma.
kind of like pushing and soft
Yeah.
looking, but it did take out the vein. Lymphoma tends to encase vessels,
And
but
there's vascular invasion anterior to the portal. Is that vascular invasion?
anterior to the portal. Wait,
Like
I think it's just
right there,
pushing.
like centrally. But maybe that's just nodular tumor.
Mm. I want to do, I do want to bring up one thing because like I think a few weeks ago we showed lymphoma that like we were like, oh, it's too hypodense and all this stuff, but really aggressive lymphomas can be hypodense and they can even take out vessels. So we still kept that in the differential, you know, some kind of aggressive sarcoma, some kind of neurogenic tumor. The clue is actually the calcs. Anything else come to mind?
Well, initially I was thinking mucinous because mucinous can have central calcifications.
Good. That's a great thought. We also were like, is it from the pancreas or is it just pushing the pancreas? Can't tell. Long story short, this was actually a neuroendocrine, high-grade neuroendocrine tumor, also called small cell carcinoma. So I don't think, I mean, I think it's a biopsy kind of thing that we need to do, but the one in retrospect looking at it, because we didn't really even think about neuroendocrine tumor, is that they do calcify, 30% can calcify. So just something to remember.
Nice. In fact, like I've seen a couple of pancreatic adenocarcinoma in which they were just abutting the uncinate process and the bulk was just posteriorly around the vessels, around the celiac, something like this.
Exactly. So you always have to be careful, like that for that case I showed you where it was like low down and it, you know, more involving the duodenum. That's like really exophytic off the panc. So we were saying like, is it just exophytic? But it just wasn't growing like a typical pancreatic adeno. You can get mucinous in the setting of IPMN, like Victoria showed us last week, but this also didn't really look like an IPMN because it was like so outside the pancreas, you know? So anyway, we got fooled.
We in our practice we noticed our urology practice was still ordering ultrasound and radiographs for renal stone follow-up. And it was a source of frustration and pain point for us in radiology. So then we approached urology about it, and then we found out from them that the main driver for their practice pattern in terms of why they do that is because of radiation dose. They wanted to limit unnecessary radiation exposure for patients who are getting surveyed because it's like an annual surveillance and you know it adds up. So we heard them and we went back to our protocols and Maria Zulfikar, she found a paper where you with the newer scanners you can get, it's called ultra low dose radio protocol for renal stone, and its effective dose is 1 millisievert, which is equivalent to a radiograph. So we asked ourselves if we can do that, and so she worked with our CT physicist Jean Payton to optimize and see how low we can get our radiation dose. So this is an image of our standard dose, which is 5 millisievert, to our low dose, 1.77 millisievert. And the image quality is pretty good. And so this was enabled because of this feature available on Siemens scanner. It's called the tin filter. And so what it does is it's kind of like the polarized glasses. You know how the polarized glasses limits the kind of light that goes through? In the same way, the tin filter limits the low dose, low energy photons that go through that don't add any value to diagnostic quality. And by putting on this tin filter, we were able to get this dose even further. We didn't get it down to 1 millisievert because on the papers that talked about this, what they do is they actually cut the lung base. So they don't include the lung base in the field of view and just scan from the top of the kidneys down to the pelvis. And for us to be able to do that, it has to be a live scan, and you have to scan from the pubis to the top, so it has to be from the bottom to top instead of top down, which is what we usually do. And we thought that was going to be too much logistical issue for our techs, so we didn't try to do that. But we got the radiation dose down over half. And some patients who get KUB, they get sometimes more than 1 KUB, especially depending on their body habitus. So when you account for those, really the radiation dose is equivalent. So anyways, we went back to our urology practice and said, look, we were able to optimize this, and we got this down to comparable to radiograph. And so now our practice is now shifting to CT, solely CT for renal stone evaluation. So it was a nice win for us because it was something that frustrated us a little bit, and so it was great that we were able to kind of push our technology a little bit to what we can do, so that we can address both their concerns and also really optimize the diagnostic quality for patients.
That's amazing, because yes, I feel frustrated every time I'm reading those x-rays and I'm like, I can't tell, there's stool overlying this, or stone, or what is this? So this is, this makes a lot of sense. Do you know if this tin filters is only available on Siemens, or
Yes.
this similar filter might be available on other types of scanners? Or you don't know?
No. So most of our scanners are just Siemens, but we have a few that are GE. So Maria worked with the GE so we actually got a protocol from another institution that uses GE that has, but it's not the tin filter. They optimize other parameters like MAS and stuff like that. So we're working on that right now.
Very cool. Yep.
So this is another patient, middle-aged, and comes with complaints of right lower quadrant pain. And diagnosis is pretty straightforward here. So that's the cecum. What do we see here?
There's a lot of inflammatory changes at the base of the appendix. Is it hopefully it's just inflammation and nothing more?
So that's the appendix.
And
so
there's
that's
multiple appendicolits.
Oh, appendicolits. Yeah, it's probably just inflammation.
Yes. What caught my eye was, if we see appendicitis begins with the fact that there is obliteration of the base, be it appendicolith or be it just lymphoid hyperplasia in children. So the appendix should dilate. So the appendix is dilated here, but at least distal 1/3, including the tip, is not dilated. So the pressure should actually transmit all the way to the tip. So that was my question, but I just said appendicitis and I moved on. This patient was operated, and histopath came out to be slightly surprising, and I learned a newer entity. So there's something called as fibrous obliteration of appendix. It starts with the tip of appendix, and there's the mucosa can be replaced, the submucosa can be replaced with fibrous tissue, and even the lumen can be obliterated and occluded. Not occluded, obliterated. So this entire portion of appendix, which is not dilated, showed changes of fibrous obliteration. And yes, there was superadded acute appendicitis.
What was it from? What caused the fibrous obliteration?
It can just happen on its own. There's no.
So it's unrelated. It just happened to be there.
Unrelated. Yeah. That's
I
about
just
it.
Googled it. There's even an acronym, FO, fibrous obliteration. When the appendix becomes replaced by fibrous tissue, can rarely mimic appendicitis. It's a result of a repeated subclinical inflammatory process, can be a part of aging, or also be caused by a neuroma or carcinoid. Which I know you can get incidental carcinoids in your appendix, so that makes sense. Like it'll lead to subacute obliteration or like inflammation and obstruction, and then causes fibrous obliteration. Cool. Patient had pelvic pain. Uterus was pretty normal. This is the hold on. Sorry. This is the right ovary.
It's really big,
That's big.
very dematous maybe.
And this is the
Is
left
there
ovary.
flow?
There
Torsion.
was flow. There was flow.
Still torsionous on high on cards, asymmetry of the
Yeah.
size.
Exactly. So just based on size, like we know that flow could be unpredictable or unreliable. This was the CT.
There's that swirling sign
Yeah, exactly.
right there.
You see a swirl right there. I'll show you in the coronal too, but like it literally is like swirled. And then if you narrow these windows, you can see those peripheral follicles, right?
Mhm.
And then the location of the ovary changes
Enhancement
too.
is
Yeah, it's
Exactly,
hypoenhancing.
exactly.
Yeah.
So we actually talked about this in our interesting case conference. Like somebody had said like they thought that the torsed ovary usually goes anterior to the uterus. And they found a paper saying like it doesn't necessarily go anterior, it can go posterior, but the more important sign is that it goes medial. So you can see this looks like medialized, right? And then the size is large, and then we have the peripheral follicles. For some reason, they still weren't convinced, and the patient got an MRI.
What?
I'm just the messenger. Anyway, and then we can now beautifully see the peripheralized follicles, the central edema, the swirl. Actually, I want to show you that swirl on CT coronal too.
so by this time ovary already has some amount of hemorrhage. It has follicular rim sign.
Yes. Hold on one sec. I just want to show you. Yeah, like this. It's kind of, I feel like it's a little easier to see if you're scrolling through, but yeah, that little thing is the twist right there. Yes, follicular rim sign. So tell us about that.
So an MR, if you see, like one of the features of ovary is like it is big, and it because it is undergone torsion, so it should be T2 hyper. But in later stages, when hemorrhagic necrosis starts setting in, it becomes T2 hypo, and the follicles which are peripherally arranged will have like even more hypo rim of hemorrhage around them. So which is this follicular rim sign.
Nice. And interestingly, I just brought up the pre. I didn't really see it, but maybe it's like too early. It's like kind of subclinical. But anyway, they went to the OR and it was completely torus, completely necrotic and not salvageable. So, oh yeah, wait, I want to show you this is the delay. So you can see it's, necrosed. Yep.
So there's this person who had basal cell carcinoma around the nose area and underwent ICI therapy, immune checkpoint inhibitor therapy. And this is pre-therapy, and we are focusing on the thyroid. So thyroid looks normal. Couple of months, I think 6 to 8 weeks after therapy, we see the change in thyroid. So it is immune checkpoint inhibitor induced thyroid atrophy. And the drug this patient was on was Seplimab.
Wow. They're now hypothyroid?
They are hypothyroid.
Cool. They must have known it was hypothyroid though. They didn't do the scan to look at the thyroid size, right?
No, that scan was just done as a part of a metastatic workup.
Oh, got it.
The patient already had symptoms and TSH was pretty high and T3, T4 were very low.
Got it. They're not completely benign, these immunologic drugs.
Yeah, you showed one example a couple of months back.
Autoimmune pancreatitis.
Yes.
So this was an MR enterography for GI bleeding. They had done EGD, colonoscopy, both were negative. So they wanted to look at the small bowel. Didn't look like dilated, but there was a finding
That
here.
Yeah.
Yeah, so it looked like thickening of the small bowel, kind of apple core-ish, and could be seen also here.
Mm-hmm.
Really nice. So, it was like, hey, is it a stricture? Is it adenocarcinoma? You need to go check out this piece of small bowel. Any other observations here?
Like that upstream bowel is also narrowed. Like that there's dill, but there's there's segmental. Kind of
yeah.
that looks thickened, so it's multi-segment.
Okay. There's
There's
another
stranding.
Okay.
Is that another segment like just where transverse colon is, but that looks like a small ball that also looks thickened lateral to this?
Okay. None of these things you said are true.
Okay.
Anyway, the only thing that's true is this.
Okay.
And the other observation is like this loop doesn't really go anywhere.
Oh, like a
Meckel's
Meckel's?
diverticulum.
Yeah.
Oh my gosh.
So they got a Meckel scan. And there it is.
Wow.
So Meckel scan is pertechnetate and it's taken up by gastric mucosa. You can see the stomach is really lighting up here. And then the ectopic gastric mucosa in the Meckels is also lighting up. It can also have ectopic pancreatic tissue. This one just had gastric tissue, but and that was what was causing the GI bleeding.
Only about 50% have like gastric tissue, right? Like it's not 100% positive.
Correct. Yep. So the rule of twos is usually 2-year-olds presenting with GI bleeding. They're 2 inches long, 2 feet from the ileocecal valve. I don't remember the other twos. But yeah, it was cute. We didn't actually call it on that MR. We said, I mean, we pointed out this abnormality, but didn't like quite put together that it was a Meckel's. But because the patient was young and was having GI bleeding and this like kind of, sort of finding, the team ordered the Meckel scan just on their own. And it was Meckel's.
I think I should. Do you guys see my video?
No, it's like a white.
So this is a middle-aged person and he comes with acute abdomen. We see that the bowel loops are dilated. And we see this segment of blinding loop of bowel, which has undergone torsion. This twists, this loop twists, and this has some mass within. So basically this was Meckel's diverticulum, which had undergone torsion. And the reason was because it had a mass inside and that mass was gist.
Oh, wow.
Oh, wow.
Sorry, this is just auto-playing and I have not much. Okay, I got the control.
I was like, this is why I don't like videos.
So
oh, I see. There's like that small bowel loop comes in and out, and then there's this big bulbous thing coming off of it that was torsed, but with a thickened base.
Yeah.
It's pretty atypical for just 2, given maybe we're not seeing like there's a really endophytic circular mass, but usually they're rounded lesions.
This just was almost like nearly totally endophytic.
Oh, that whole thing is the gist.
Yeah.
Oh, cool. That's
Gist wasn't exophytic. Sorry. Yeah. Go ahead.
Yeah, no, and it's endophytic, but it's the whole thing. Yeah.
Yeah.
Cool.
You want to see a SAG also? So that entire thing is Mikkels with gist.
Nice. Very cool. Okay, going down to the pelvis.
Hydrogel of prostate therapy, I mean, to give, to give radiation in prostate cancer, hydrogel, this is the hyperdense variant.
Yeah, exactly. This is a spacer. Just to show what it looks like on CT, because we often show the MRI. And this type of, they actually make it specifically radio dense so that you can also see it on CT. It's a really nice example of a good positioning of one. We have had cases where it looks like it's in the rectal wall, which is not ideal. It's not itself toxic, but it can cause necrosis. And it also can cause like, not enough radiation protection of the rectal wall. So ideally they want it in this very narrow space between these two. They do it transperineally and put it in that very thin space there, and then check it on CT or on MRI.
Mm-hmm. In fact, the first generation was without iodine, so that was hypodense on CT, and for correct positioning, they always needed MR, so which was unnecessary expenditure. So that's why the second generation is with iodine, so they can just do limited CT of pelvis, and they can just plan like faster the radiotherapy.
Yeah, exactly. And just for a correlate, this is what it looked like on MR.
When we do the post placement, we get an MR and a CT.
They actually did both. They did both.
Why do they do both?
Well, this was actually called MR rad planning. I think this was like during the actual placement, and then the CT was like a week later. So I'm not sure exactly why they got the CT a week later, but maybe to make sure it was still in the same spot before they did their second radiation.
There was another modification that was done, and it's the viscosity of the material. So the first version of it was thin, so it kind of moved around easily. Now the current versions are thicker, so it stays put.
Cool. Okay, so you can see that there's extensive liver lesions, probably metastatic disease.
Is the cecum thickened? Yeah, that thing. Cecum or ascending colon. Yeah, yeah.
Yeah, so do you think that's a mass? Do you think it's colitis?
No, that looks mass-like.
Yeah, good. So I wanted to show this because the prelim was that, there was colitis here, and it does look pretty hyper enhancing. But to me, the clue is that there's actually like confluent lymphadenopathy coming right out of the mass. I'll show it here. So you can see, it kind of could mimic colitis. It's very hypervascular, kind of a long segment, but here we can see that there's tumor, like either direct extension of tumor or like this confluent lymphadenopathy coming right out of the mass. So then it makes it like extremely suspicious. So yeah, this was a colon cancer, extensive liver mets. The colon cancer was actually only this big, but yeah, it had already spread pretty extensively in the liver. So always follow the colon, and if there's adjacent lymph nodes, be very, very suspicious.
So we spoke about the whirlpool sign, the twisted pedicle in ovarian torsion right now. So that also is something we see in testicular torsion. So we see the twist here, something which looks like cut slice of onion, and that's the ultrasound video, and we see the twist one more time. So that's the twist that we see. That's about it.
Very nice.